Before we start, I just want to mention that these works that I'm going to present to you were done by the collaboration of our lab, Kishony lab at the Technion, with our collaborators from Maccabi, which is the second largest health organization in Israel. Okay, so let's go back in time for a moment to understand the context of this work. So in December 2020, the FDA authorized Pfizer vaccine after clinical trials showed very high efficacy in preventing disease. I could guess that many of you still remember this quite beautiful and optimistic graph from their phase 3 study. You can see that the vaccine effect kicks in already about 12 days after the first shot. And right after the authorization in December, Israel was the first country to vaccinate its population. And later on, having real-world data, it was shown that in case of breakthrough infection, the vaccine still prevents severe disease. So it seems that there is a double-layered effect on the individual after being vaccinated. First, the probability of being infected is lower. And second, even if you are infected, there are less chances to have a severe disease. However, at this point, it was still unknown how the vaccine affects the viral load and therefore the viral shedding in case of breakthrough infection. The answer to this question is important because if vaccinated people have lower viral load than unvaccinated, it means that they're not only more protected by themselves, but also their environment is more protected because they're less infectious. In order to answer this question, we decided to take advantage of the data from Maccabi's PCR test results. The PCR tests were carried in one central laboratory, so these results could be compared to each other. Just a brief recall on the PCR itself. In the PCR process, we amplify the DNA fragments we have in our sample. In this case, of course, RNA, where they are multiplied by approximately 2 in each cycle until it reaches an amount that we can detect. The process then stops after a number of cycles of amplification. This number, the cycle threshold or CT, is therefore inversely correlated with the log of DNA copies in the sample. So the higher the CT, the lower the viral load. I want to note that it is not 100% accurate. There might be, for example, non-viable viral particles in the sample, but these fragments are still amplified. Also, speaking about infectiousness, the viral load is not the only factor, and one variant can be much more infectious, but still with lower viral load. So CT is a pretty good proxy for estimating viral load and infectiousness within a specific variant, but we have to remember that first, these terms, viral load and infectiousness, are not identical, and second, that the comparison can be done only within one variant at a time. So first of all, we crossed the data of laboratory test results with the data set of vaccination status. And then we look, then we took all the people that had a positive test result after being vaccinated, what we call a breakthrough infection. They counted for about 5,000 people. And again, it's a nationwide healthcare provider, so it is not limited to a specific portion within the population. And looking at their CT values in each day after vaccination with the first dose, we could see that there is an increase of the mean CT already after about 12 days. resembling the time that Pfizer saw in their trial regarding the effect of preventing infection. But it was not enough because there is no control group here to compare to. So we next crossed again the data sets and took a control group of unvaccinated people that got infected, matched to the vaccinated group by their sex, age, and the calendric date that their test was carried on. And indeed, while in the first 11 days, we could not see any difference between the vaccinated and the unvaccinated groups, in the later days, there was a significant difference. And to better quantify the effect, we then applied a linear regression model on the data of both vaccinated and unvaccinated people. The model took into account the patient's age, sex, date of test, and also time post-vaccination. And we found that vaccinated individuals had an increase of 2 CT units, which can be translated into 4-fold reduction in their viral load. And these results were from a pre-Delta wave. However, about 6 months later, we saw a new surge of cases in the country where Delta was the dominant variant. And some reports showed that when comparing now in the Delta wave, vaccinated and unvaccinated people, it seems that the vaccine is not producing viral load anymore. And it was unclear whether it is a matter of the new variant, that is, the vaccine does not affect the viral load at all in case of Delta infection, as some reports claimed, or maybe it is just waning immunity and it has nothing to do with the new variant. So we retrieved the updated data from the beginning of the Delta wave and analyzed it. And we found that the vaccine is effective also against Delta variant in regard to reducing viral load, as you can see here. And right after the first 2 shots, the vaccine was highly effective, as we've seen before. And among vaccinated people, there was an increase of about 4 CT units compared to the unvaccinated. But the thing is that after several months, this effect wanes and ultimately vanishes. However, at this time point, the country began administering a 3rd shot, a booster shot. And the good news were that the booster restored the previous effect. Our results also agreed with the previous reports of no effect, because for most of the population, the effect has already waned. And indeed, when we aggregated the vaccine group and looked at them as a whole, when we aggregated the data for the vaccine group, we saw no effect, as you can see here, or at least a little effect, a little one. All right, but still looking forward to the future, it was again a bit vague. Will the effect last for longer now after the booster shot, or maybe it will wane just like after the 2nd shot? So we waited, and after a few months, still before Omicron became the dominant variant, we saw a similar pattern of waning after the booster shot. And as you can see here, there is an initial effect after the first 2 shots with increased CT, and this effect then wanes and being restored after the booster shot. And later, the restored effect also wanes in a similar manner. So to sum up what we saw so far, we saw that there is an effect of the vaccine in addition to the more classic effects of preventing disease and severe disease, and that is reducing the viral load in case of breakthrough infection, and therefore also reducing infectiousness. This effect seems to be relevant only for short periods of time after inoculation with the vaccine, and it vanishes quite quickly. Okay, so these results are true for the individual level, but how does it work in the population level? Or in other words, is there any evidence for a community level protection of unvaccinated individuals? So Oren Millman from our lab decided to tackle this question. And in order to do that, first he divided the country to multiple geographical areas that define different communities in the population. He included only communities with more than 2,000 people to avoid noise. And next, he calculated for each community the fraction of vaccinated people and also the positive test fraction. But if we want to see the effect of vaccinated population on unvaccinated one, we have to have different cohorts of these populations. And normally, belonging to one of the two cohorts might be due to many confounders and might bias our results. But here's the nice thing that he came up with. At that time, children younger than 16 were not eligible for the vaccine, so they were great candidates of being a control group. So the fraction of vaccinated people was calculated for people older than 16, and the positive test fraction was calculated only among children younger than 16. And you can see here both measures over time for all the communities, where each community is represented by a different line. Then the ratio between the change in vaccination rate and the positive test rate of 28 days later was calculated. And this ratio for each community is presented here. And you can see that the positive test fraction in the unvaccinated cohort decreased in proportion to the rate of vaccination in each community. And a linear fit shows a strong negative association between the log transformed odds ratio of the positive test fraction and the increase in vaccination fraction. This graph is in log scale, so it might seem as a weak slope, but on average, we can say that for each 20% of individuals who are vaccinated in a given population, in a given community, the positive test fraction for the unvaccinated population decreased approximately by twofold. This ratio, represented by the slope, was calculated here by a specific interval of dates, but when tested for different time points, they saw the same effect, and the results were quite robust. Of course, that this effect stems not only from the reduced viral load that we've seen before, but also and probably mostly from the effect of partial herd immunity. Finally, I want to mention another study, not from our lab. It's done by our collaborators from Maccabi. They built a statistical model that describes the probability of being infected given the data of other infected people in the same household. That way, they could find that the vaccine effectiveness against infectiousness given infection in the same household was about 20% during the first 3 months and later waning until it vanished. And these findings are of course in agreement with the Foreman studies looking at the viral load reducing effect and also the community level effect we've just seen. So to conclude, we saw that the vaccine has a short-term effect of reducing viral load and therefore also the infectiousness in case of breakthrough infection. This is a short-term effect that wanes after some months and can be restored with more booster shots. In addition, we saw that the protection effect of the vaccine is extended beyond the individual level and that there is an evidence for wider immunity. Finally, I would like to thank all the collaborators again, both from our lab and from Maccabi. It was really great teamwork. Thank you for your attention, and I'll be happy to take any questions.
Well, thank you for a wonderful talk, very interesting and important data. We now have time for some questions. I want to start off, I have two questions. First of all, when you looked at the community level protection, were you able to control for masking?
Okay, so masking and generally speaking about behavioral effects is always a problem in such studies. But the advantage of this study was that we compared each community to itself in different time points. So we compared a specific community, their adults to their children in an interval of 28 days. So if you think that, I don't know, in one community they wear masks more than in other community, so we compare only to the same community later. So we try to cancel this bias that way.
And another question was, do you have any data on whether there's a correlation between viral load and severity of clinical disease?
Okay, so it's not from our studies, but yes, there are evidences for a correlation between viral load and the severity of disease. And to make stronger our findings, we also repeated the analysis with excluding severe cases to see if it's maybe biased by these cases. And no, the answer is that the increasing in CT and the decreasing in viral load is in the whole population and not only in severe disease.